Again, I'm going to ask, can you see that?
Yes, Prof, we can.
Yes, we can.
Oh, wonderful. Thank you very much. So we're going to do lung imaging this morning. Now, I have to say that when I did this last 2 years ago, it was sort of interesting, but it's sort of got a lot more interesting in the last few months as the world has obviously started to suffer from a lung-based disease, and we still really don't know the role of nuclear medicine in this new disease, but I've got some new data which I think is quite interesting. So even if you don't think, if you think you know it all, we might get something new. But we'll start off with old-fashioned VQ lung imaging. Now, there's only one agent to do the perfusion imaging, and that is technetium MAA, which is a macro aggregate of albumin, which basically just blocks the small vessels within the lung. And the idea is that the particles only embolize around about 1% of the smaller capillaries, so that it doesn't really change perfusion very much. Ventilation agents, there's a mixture. In most of Europe, we use a gas called Krypton 81M, which comes from a rubidium generator. It has a very short half-life, but the big advantage is that it dissipates very quickly, so you can use it very easily. Then there's a mixture of different types of aerosols, and different companies and in different countries, there's different delivery systems for that. Then there's the Technogas system, which is basically a smoke generator. It produces very small particles and is the closest non-gas to a gas, if you see what I mean. And then there's the xenons, of which Xenon 133 is the most common. I think only the United States really uses xenon. There are particular issues with xenon. The biggest issue being is that there's lots of radiation protection issues, because if staff breathe in xenon, if the patient is having trouble breathing, then it's very lipophilic, and it has been linked to patients getting, not patients, staff getting lung neoplasms. So we tend not to use it outside the United States. SPECT has really changed the picture with VQ lung scanning. It was sort of dying off, but since we got SPECT, we found that many more people are using it. Okay. So Xenon Gas, just talk a little bit about it. It's got a very long half-life. It's about 15 days. So you can only take a single view, normally posterior. And in the American studies, it led to a large number of equivocal results. And you have to use it on a rebreathing kit, which will absorb any expelled xenon onto basically a chalk-like substance. So it's not very good for those people who are short of breath, which unfortunately is the main group of people we want to scan, or those who are on ventilators. The advantages of aerosol type systems is that they're cheap and easy to use. These aerosol systems got quite sophisticated. Originally, they were just based on the same nebulizers used for things like salbutamol. And they try to produce fine particles which penetrate the airways better. And the better the distribution, the slower the clearance from the lungs by the mucociliary system, though they will clear. Now, that has an advantage. You get some good pictures, but the disadvantage is that you have to do the aerosol first. And then you have to wait for the lungs to clear before you do the MAA scan. And that can be 40, 50 minutes waiting for that to happen. But it stays in the lungs long enough to get a good quality SPECT, which is useful. Krypton, as I said, is used mainly in Europe. It has a short half-life of 11 seconds. And you have a rubidium 81 generator, which comes in a pot about the same size as a bean can, but it is fairly active in terms of radiation activity. So that itself is then stored within a quite heavy lead pot. The rubidium is manufactured in a cyclotron. It needs to be a reasonable size cyclotron, and there's several of those across Europe that do that. It produces a quite energetic gamma, 180 keV. So depending on your gamma camera, you can use low energy or medium energy collimator. Most modern gamma cameras are designed to use the low energy collimator, so you get better resolution. Also, the 180 keV is just far enough away from 140 keV for the MAA that you can do simultaneous acquisitions. It is very easy to give via a ventilator. There's almost no radiation protection issues because the patients just don't breathe it out. It decays within the patient. And it's you can use it with SPECT. So here we have a very normal planar VQ scan. Typically, you take a series of images, anterior, posterior obliques, and you can also take laterals as well. If you're ever in an exam situation, of course, the way to determine the ventilation scan, if it's not labeled, is you look for the trachea, because the trachea will be visible on the ventilation study. Sometimes you see central airways with aerosol as well. Now, don't get confused, because in a perfusion scan, you may see thyroid uptake if the MAA has got a bit of breakdown. So just look at the structure, and this clearly is a trachea shape. You can see it's very linear. So there are various different reporting methods described, and these are the American ones, which is the Bailout report system, which is also used by an infamous trial called PIAPED. And they wanted to go for this probability-based reporting system. And this is what they had down. This is that you could have basically 4 different types of report. So if there was just one segment of VQ segment, that is one segment out in perfusion with normal ventilation, the answer is that there's less than 5% probability that that will be a pulmonary embolism. And this is all based on comparing VQ scans with pulmonary angiography in this PIAPED study. The high probability is more than 2 segments, or once, and it should be in both lungs, which is a bit odd because we all know you can get pulmonary emboli in one lung, or a whole lobe, and they describe that as more than 95% probability of pulmonary embolism. So indeterminate is 2 segmental VQ defects in the same lung, or abnormal ventilation. And again, if you think of the average patients that you're looking at, that's pretty well encompasses quite a significant number. And as a consequence, in the PIAPED study, the number of cohorts was around about 35%, which really makes it pretty much a useless test. Later on, they allowed you to have a normal study where you could just report normal. But some places still want to use these probabilities for reporting. But as a clinician at the other end, getting a report that just has probability is pretty useless. Now, we said that PIAPED's main problem is it used Xenon, which only gave them one view ventilation, just posterior. And that's, as we know, is not really very good at confirming the cause of abnormality. And I said the probability reporting system isn't really helpful to clinicians. So this is a slightly more realistic view that you can get. So this is again with planar imaging. So we have here the perfusion scan, and we have here the ventilation scan. And you can see that there's a differential perfusion and ventilation in the 2 lungs. Here we have a relatively normal perfusion. This is the posterior view here. So here the sorry, that's anterior view, that's the posterior view. So the left lung has very poor perfusion, but in fact, if you look here carefully, the ventilation is even worse. Now, if we saw this scan in 2020, we would in our head say, I wonder if that's COVID. And I'll show you some pictures with that later. But there could be various other causes for this, including if you've got a reduction on both sides in the whole lung, extraneous pressure on the relevant pulmonary artery and the bronchus, normally by something like a hilar lymphadenopathy, which could be related to a tumor. So this kind of patient would be better seen with a CT-based device. This is another patient. Here we have a perfusion scan across the top, and these are the perfusions, and these are the relevant ventilations, again with krypton. And here we have just very subtle changes, subsegmental changes here. But if you can see, they seem to be pretty well matched. So this patient probably has some parenchymal lung disease. And I think that it would be a very brave person who said this patient had a pulmonary embolism, because we don't reach that sort of segmental level for reporting that we have significant defect. And subtly, if we look very carefully at this ventilation here, it's reduced more than perfusion. So it makes us think this is primarily a ventilatory disease, and this is often due to something like consolidation due to a chest infection. This one, on the other hand, is a lot easier. We can see here multiple segmental and subsegmental defects throughout both lungs with normal ventilation. I think most of us would be very happy to report this as multiple pulmonary emboli. Now, we don't live in a world without other techniques, and the technique that is primarily seen as a competitor for VQ lung scanning is the CT pulmonary angiography. But there are issues with Ctpa. In many hospitals, CT is oversubscribed. Maybe in South Africa, you're fortunate enough to have lots of extra CT scanners, but here in the UK, we have a waiting list for CT most of the time, and trying to fit in urgent Ctpa patients, even having a CT based in the emergency department, has proved to be an issue. And our radiologists don't want to spend their whole time doing CTPAs. They want to get on with the work, for example, in staging or restaging cancer. There's also some significant issue about radiation dose. Now, the radiation dose of a modern CTPA, to be honest, is not much different from the effective dose from most VQ lung scans. But that's not the issue. The issue is the breast dose in women. And then in particularly, the breast dose in young women. One of the reasons being is that anybody who's been in an ED department or a nuclear medicine department or radiology department knows that vast quantities of young females who are taking the oral contraceptive pill, who always seem to have been on a long journey recently, turn up with various breathlessness or chest pain. And they all have their D dimers taken, and those D dimers are always slightly elevated because, to be honest, everybody's D dimer seems to be slightly elevated. I've not seen a normal D dimer in years. So they go down an algorithm path, which says they must then have a test to rule out pulmonary embolism. And because younger women tend to have denser breasts, they're very much more get a much higher radiation dose from a CTPA than older people or men. So The real issue is that the breast dose from Ctpa is between 4 and 6 millisieverts compared to the overall dose to the whole patient have only been around about 1 millisievert. And that again is an issue because we do know from the work done with mammography that 4 millisieverts is at the threshold where it may be possible to initiate a breast carcinoma. So we have a question. Good morning. What is the current VQ practice in the UK? With COVID, you're going to have to wait. It's coming up. Be patient. I will answer that in a minute. I can't do the most exciting bit first, so you're going to have to wait for that one. Okay. Now, so what we decided is that during normal working hours, nuclear medicine acts as a gatekeeper for Ctpa. So we tend to do VQ scans on almost all patients. And since we have VQ SPECT, we can do it even with abnormal chest x-rays. And I'll show you later. And then those with equivocal VQ or known lung disease or abnormal chest x-ray may be considered for Ctpa. Now, to give you an idea, we do an annual audit in my hospital, and in that annual audit, only 2% of patients are equivocal. By the way, somebody is singing with their microphone on. They might want to turn it off. There are specific issues with Ctpa as well. You need to have good circulation time, which means that patients who are have got heart failure tend not to do very well with it. Also, in patients with atrial fibrillation, the computer system that calculates when to do the actual CT acquisition can be confused by atrial fibrillation. It's very good for the larger vessels, but not very good for peripheral pulmonary emboli, certainly the subsegmental one. As we said, the breast dose is very high. So this is some work that we did in my previous hospital, just looking at 300 cases, comparing, this is in days of planar VQ versus Ctpa. And you can see even then, compared to the PIAPED, we had a very significant reduction in the equivocal rate compared to PIAPED, just 12%. So with VQ lungs, that goes down even further. Of those equivocal patients, most of them on subsequent Ctpa were actually negative. So you can see how you can use VQ as a gatekeeper because you've turned 272 requests into just, in fact, you can see there was 98 done. Some of these were done because of other problems with their chest x-ray. But overall, you're saving the radiology department quite a significant amount of CT time. So the risk factors for a positive study. We reviewed this in 3 series of patients over the 80s, 90s, and noughties. And they're pretty consistent. The biggest increased risk is old people. Old people are much more likely to get pulmonary embolism than young people. Recent major operation is not unsurprisingly a big risk factor because patients are immobile, and even giving patients subcut heparin, it remains a significant risk factor. Recent immobility of more than 1 week, and this would be for any reason at all, but recent immobility due to illness primarily, and the illness itself can be a risk factor. If you're measuring their oxygen level, which you should be doing, then hypoxia on oxygen is a good risk factor. And just being breathless is a risk factor. Yes, we could add COVID to the risk grade, but I'm going to do the COVID in a minute, so just give us a chance. Be patient. I'm trying to build up to it because I've got some interesting slides on COVID coming. You're all impatient. Okay, interesting. Hemoptysis was not a particular risk factor, partly because people get hemoptysis with chest infections. And the only thing that was protective, the only thing that gave you a less chance of getting a pulmonary embolism was going on a long air journey. So all this story about going on a long journey gives you pulmonary embolism doesn't appear to be true. And this is partly because, to be honest, air travel is not done by old people who have had a recent major operation and immobile, due to the fact that if you're bedbound, you can't even get on the plane. So it tends to be done primarily by young, fitter people, and they don't get pulmonary embolism as common. Suspect lungs. Now, this is recommended by the EANM for diagnosing pulmonary emboli, and this was developed by Marika Bailout in Sweden. And the idea was to try and reduce the rate of equivocal results. It can be technically difficult with some ventilation agents, but if you use krypton, then it seems to work okay. And also the technetium aerosols, it works well, but you can't do this with the xenon at all. So the Americans have had difficulties because they use krypton and they can't do SPECT with it very easily. So this is just some of the early pictures, and this shows these are not planar views, these are coronal SPECT views. This is the ventilation, and this is the perfusion. And you can see very nicely on the perfusion image that you have two defects here. This is from the original paper in the guidelines, and this was confirmed using Ctpa as part of the original study as being due to bilateral pulmonary emboli. And the bottom panel is a patient that again is normal. And here we see very nicely in the coronal image, you can look at that. In fact, this patient is the same patient, C and D, but after 6 months of anticoagulation. And if you look very carefully, there's one small defect that doesn't quite improve. So this is the method that we primarily use in the UK now, and I'm sure you do the same. This was another patient who has got a horrendous lung disease, and this is done with an aerosol, and you can see it's an aerosol because here in the ventilation you can see some pooling of activity in this large bulla at the top of the right lung. And you can see pretty well here, though you would say, oh, that may well be a pulmonary embolism. In fact, when you look at the anatomical imaging, you can tell that this is pooling in the bulla, and it's not due to a pulmonary embolism. There's just no lung there. It's just a sort of empty cavity. If you were doing krypton, you wouldn't see any ventilation there, so you would know there wasn't any activity. So when you are using an aerosol and you do have patients with large cavities in their lungs, look out for this pooling, because that's a sign of abnormal ventilation. So that doesn't mean to say it's a pulmonary embolism. And again, this is a later image. So you can get a lot more information with SPECT than you can with planar, but just make sure you don't over-report it, particularly if patients have got significant COAD. If you do SPECT CT, of course, then you solve that problem because you've got the CT done at the same time. Sorry, I'm just trying to get this thing to work. So here we are. Here's one for you. So, and they get you think. What do you think of this? What's stick in the chat box what you think is happening in this one. So just give you, this is the perfusion and this is the ventilation, and this is a sort of the perfusion matched on the edge of the ventilation. So what do you think is going on in this patient? Come on, somebody say something or chat.
I would have said the study is positive for PE.
And whereabouts is it positive?
Sorry?
Whereabouts is it positive?
In the left lung.
Okay, so this is the perfusion. This is the ventilation. Perfusion top, ventilation bottom. Okay.
Yeah.
Left lung. Okay. Yeah. So you're talking about this is the left lung here. Yeah.
The anterior segment and the
yeah,
superior lingular.
absolutely. And you can see very nicely here as well. There's two perfusion deficits with normal ventilation. So to me, these are very easy to read, and you don't need to follow the pipette rules anymore, because if you see any kind of defect, now there's another subtle one. If you look very carefully, the apex of the right lung, you can't clearly see the apex, but you can in ventilation. And the other thing is you don't see part of the left lower lobe at all, so the right lower lobe at all. And here you can see it's a little bit reduced in ventilation as well, but it's still present. So there may be, for example, a previous infarct. So this patient may have been having issues for a while. Good, thank you very much. That's good. I'll just get rid of chat for a second. Okay, so this is what happens in influenza. Now, the question is this also the appearance for early COVID? And the answer is it could well be, actually. So this is influenza, where you have a relatively normal perfusion and you have defects in ventilation. And particularly here that you can see in the right lung, in the right lower lobe. Sorry, the ventilation MIP image isn't very clear, but here you can see quite significant reduction in the ventilation, but there's normal perfusion. So when you see these big defects in ventilation and normal perfusion in a particularly young patient, then you've got to consider influenza. And I think these days also early COVID, but I'm going to show you some more COVID pictures soon. It's not long now. But what about pregnancy? Because the other thing is that one of the groups of patients we do get asked to see quite significantly is patients who are pregnant. And again, the issue about breast radiation dose is an issue in pregnancy because the breast tissue becomes even denser. So the radiation dose climbs up to nearly 8, can climb up to nearly 8 millisievert in some patients. So Ctpa is not favored in women that are pregnant. The other problem is, as you know, in particularly the more advanced pregnancy, patients lying flat can find it difficult because they have issues with the venous return because the uterus pushes on the IVC, and they can end up with some significant circulatory issues. So they would rather be imaged sitting up, and the only technique that does that is planar perfusion. If you just give the MAA, the radiation dose to the uterus is about the same as Ctpa, and that all just comes from scatter. The breast dose, though, is much less. It's about 0.1 of a millisievert into the breast, which is about the equivalent of about 2 months of living in most parts of the world. So you can say it's not much worse than just being alive, really. If the perfusion is entirely normal, and I suppose when we did our last survey, we did 150 perfusion scans on pregnant women in Addenbrooke's in 2018. 3 of those had a slight abnormality on. So what we then did was a 1-view ventilation with krypton, which obviously is not available. We don't have krypton, and they were all matched defects. The last time I saw a positive in a pregnant woman was about 2.5 years ago. So a lot of patients, and towards the end of their pregnancy particularly, present with the symptoms that are suggestive of pulmonary emboli, and this is clearly mainly musculoskeletal because there's often a baby kicking their ribs on the inside. Also, as the lower abdomen expands, it pulls the chest wall, so you get various sort of musculoskeletal aches and pains, which can appear quite pleuritic. So you don't really want to do a test which involves significant radiation dose to the maternal breast tissue. So we do a lot of them, and to be honest, most of them are entirely normal. We also halve the amount of MEA we give to further reduce the dose to the patient. So here you are, inpatient people, COVID. So COVID has really changed lung scanning in a negative way and a positive way. So let's do the negative way first. So the real issue with COVID is that these patients are really pretty infective. Now, inhalation of agents with COVID isn't really a problem. So you can use any agent to do a ventilation scan. But it's expiration which is the issue. And this is especially if the patient is unwell and therefore not in full control of their breathing. And of course, you're going to be doing a VQ scan on patients who, for example, are short of breath. So they're going to have breathing issues. Now, we know that if you're just breathing normally, you can actually, this is not coughing, this is just breathing. We now know that COVID can travel around about 2 meters in air, which is the reason why we ask people to wear face masks in public. If you're using a mask to give the aerosol, patients who are short of breath may not be able to keep their mask airtight. And this means that there is a risk to nuclear medicine staff assisting that patient. So here is, and we've all seen these kind of diagrams where people look at what happens with particulates. So this is just breathing in and out gently through their nose, not even through their mouth. And you can see that there's a swirl of aerosol particles around the person, which extends out. This is 0.3 of a meter. But you can see there's a significant aerosol just produced by normal breathing. Now, if the patient hasn't got COVID, that's not so much of an issue. It may be an issue they got TB or influenza, but not if they're not infected. If they cough, then they get a much further explosive movement of these particles. And I'm sure we've all seen those things on television of aerosols being blown out of coughing patients' faces. So the main concern with patients who suffer from COVID is they may be breathing or even coughing COVID around the waiting room, the injection room, the corridors to nuclear medicine, around nuclear medicine, and the corridors back out of nuclear medicine, as well as the fact that in an actual scanning room, which even though it's well ventilated, staff may be close to patients, they may be an additional risk. So we put together some recommendations at the British Nuclear Medicine Society, and these are available free on our website. And these recommendations are as follows, and these are pretty similar to the recommendations that are being produced by, for example, the SNMI and the ENM. So do perfusion only if possible. If you have a SPECT CT, you can do SPECT perfusion and CT, the lungs. If you do need to use krypton, use krypton if you can. Now, obviously, you don't have krypton, you can't. If you're using the aerosol, then you have to go up to what we call FPP3 level respiratory PPE. Now, some countries use N95, but FPP3 is tougher than N95, and N95 is not legal in the United Kingdom. So we use, or anywhere else in Europe. So we use FPP3 masks, and this is a type of mask that is an FPP3 mask. And you should obviously wear gloves, gown, and apron, so as well as a visor. So this is the kind of thing you need to wear if you're actually going to be in the same room as a patient with COVID. Now, most of the patients that are going to be treating with COVID are going to be having lung problems. So, and as previously mentioned in the chat box, COVID itself is now a risk factor for pulmonary emboli. So it is a group of patients that we may come across. So we do need to protect our staff and ourselves if we're in the room at the same time. So this is just an example of how you can use the perfusion SPECT and CT in looking for pulmonary emboli. Now, this is a patient who has got multiple pulmonary emboli, and this was a paper from 3 years ago, but you can see very nicely that if you can map the perfusion over the CT, you have here multiple perfusion defects. If you look at the CT, there is no significant consolidation or abnormality. So this would be consistent with pulmonary emboli. Now, you may say it's not quite as good as a ventilation, but in terms of safety, it's probably the best that we can do. So if possible, I would suggest using SPECT perfusion and CT. And if you do that, if the patient's just wearing a normal surgical mask and staff are wearing normal, what we call normal non-respiratory PPE, which is surgical mask, gloves, gown, and apron, then you should be fine then. But COVID itself is an interesting disease. It's an evolving area. We're beginning to learn much more about COVID in terms of what it does to people, in terms of its lung inflammation and damage. And there are a subgroup of patients where some of this inflammation doesn't seem to reverse. We may see changes on a FDG PET CT, for example, if we're doing, or even a PSMA PET CT, if we're doing a scan for another reason. But also we might say this is a sort of opportunity because there are going to be a group of patients that we need to monitor what's actually happening in their lungs. So we might want to look at perfusion SPECT CT to monitor what's going on in patients' lungs over time. So though it's a relatively new condition, there has been a series of publications that have come through. Let's see what's in the chat. So due with perfusion SPECT CT increases the false positive rate for pulmonary emboli diagnosis. The answer is we don't know. Obviously, we don't have a ventilation, but I think it depends how experienced you are reading CT chest. We don't really have any good data on that. I think the probability is that it might result in some slight increase in false positive rate. The difficulty we have, of course, is that we don't really have an option. So it's better than not doing the test, if you know what I mean. So yes, we just need to be aware of that there may be false positives that we are missing. Absolutely. We may get some further data on that coming out. There are people doing projects on this at this very moment, but obviously the problem is you can't really do the ventilation part to compare it with. There's another question coming up in chat. Just trying to get chat to come up. It's computer's been a bit of a pain. Okay, whilst I'm trying to get the computer to work, I'll just look at this study. So this is an 82-year-old patient who lives in Italy. Now, if you remember, the second biggest early spike of COVID was in Italy. And this patient had come along, was an outpatient, evidently had come along with a rise in CEA 6 months after chemotherapy for carcinoma of the colon, and had come for an FDG PET scan. And in fact, there is some uptake down here in near the colon, which they think may be the primary site, which is still present. Yeah, I agree, as you say. We just don't know the full answer yet. We have here multiple areas of focal uptake of FDG within the lungs, and we see a pattern of abnormality within the lungs, which we're now used to seeing in COVID. But remember, this was published in April 2020, when most of us hadn't even seen the patient with COVID. And you can see these areas of, at present, at the time, it's a very acute stage, so it's still consolidation, it's not yet fibrosis. And you can see that it's a very active inflammatory process by the amount of FDG uptake. So this is now something that we probably have seen much more frequently. But at the time was the sort of first report of such a scan. Just try and get the next chat. So you just yes, I think we have agreed that doing just the perfusion and CT does increase false positives, but as I said, the problem is we have to do what we can in terms of safety and compromise. So we do understand that, but this is probably the best we can manage at the moment. This is from another Italian group, and this was published online in the JNM, and one of the first pictures online. And this patient is starting to move into the next stage of COVID. So this is the normal lung windows, and then there's what they call the hyperlung windows. And here you can see there is in fact some early fibrosis, but the fibrotic stage doesn't really have FDG uptake. So there seems to be two phases that we see in COVID with FDG PET. There's the active inflammatory stage, which can be very FDG avid, and then there's a later fibrotic stage where FDG activity is reduced. So we can use FDG in some way to monitor that. The problem with the fibrotic stage is that we don't know if it's irreversible, but it does seem to be, even if it's not irreversible, slowly reversible. So patients with fibrotic stage COVID, we know can still suffer from dyspnea 6 to 9 months after their initial infection. So what about lung scanning? Now, this is a group from France, from just outside Paris, and this was published in the summer. And again, France had a very significant COVID infection. This is done with an aerosol, this particular one with an aerosol ventilation. They got permission to do this because they're doing it as part of research. And you can see here in this patient with COVID that we have quite a big perfusion deficit. A is the perfusion, B is ventilation. And what you can see, even though the chest X-ray or the chest CT is relatively normal, there's very disrupted ventilation with the aerosol. So, and this I understand again is fairly typical if you're using ventilation in COVID patients. You can get this very patchy change, but not there's no defect at the site of the perfusion defect. So we've got two different pathologies going on here. We have a vascular pathology that's causing the pulmonary embolism, and we have a widespread, probably alveolitis or pneumonitis, causing the ventilation appearances. This is probably one of the most comprehensive papers. So I'm going to show a couple of pictures from it. This is from the same paper. Now, this patient has got much more of a fibrotic change here. And what you can see is, again, obviously clearly here, this is the perfusion, this is the ventilation. Where you have fibrosis, you don't get the ventilation, so you've got ventilatory defects. But in addition to that, you have this wedge-shaped perfusion defect, which isn't entirely matched on the ventilation. Within the commentary, they say, again, this is a patient that's getting these mixed pictures where they're getting fibrotic changes, but also they're getting vascular changes. And we know that in COVID, you get a vasculitis. And so what we don't know is whether or not we can now use this technique to monitor patients over time. Now, remember, with a patient like this that we're doing a full perfusion ventilation, this ventilation was done with krypton, so the image quality is slightly better than with an aerosol. Each patient, staff can have to wear a new set of ventilatory PPE, and when everything's done, everything needs to be decontaminated, including the room, the gamma camera. The staff are going to need to do a change of clothes, etc. So these are not studies to do lightly. They will have significant impact on the department's running. And this again is a patient with long COVID. So this is 2 months post-COVID, still short of breath, and a 69-year-old. So long COVID can occur with anybody. And what you have here is, let's go to panel C. You've got the CT shows these very subtle ground glass changes in the periphery. I've seen these on PET scans now that are coming through for patients with cancer quite frequently now with patients who have had COVID. And around about 5% of the population of London now has had COVID. So they're going to start impacting on just routine PET CTs. And you can see here, the panel A is the perfusion, which is relatively normal, but the ventilation here is markedly reduced in areas where the CT scan is normal and the perfusion is normal. So we're picking up big ventilatory defects that persist despite a normal CT. I think that answers one of your questions about can you get false positives, but also you could possibly get it the other way around. In fact, we can see ventilatory defects without CT abnormalities if we did it that way around. So I think we do need caution, particularly in these patients who may have COVID, because we're just learning the patterns that we can see. And I think if there's any doctor in the world who tells you they know what to expect with COVID patients in the VQ lung scan, they've probably been drinking something they shouldn't. Maybe they've been drinking hand sanitizer or something, because we just don't know yet. But we're learning and we're finding out. So remember, everything is an opportunity as well as a problem. So if you see things in South Africa that are not reported, then please publish them. Interestingly, if you get a COVID lung paper sent to one of the major journals, they seem to both accept it and print it in around about 3 weeks. So if you want to get your CV up to date, then a COVID paper seems to be a very good way to do it. I'm just going to finish off with a little bit on aerosols outside of COVID in patients who have pneumocystis carinii pneumonia or Giovanni carinii pneumonia. This is a technique developed by Doherty et al. About 25 years ago. And one of the things with aerosols, in normal lungs, aerosols generally clear by mucociliary clearance, as you know if you use aerosols. But in patients who have a pneumonitis and patients who have PCP pneumonitis, then what will happen is that there's a blood-brain barrier, there's a blood-lung barrier where substances can't pass through unless they're lipophilic. But if that barrier becomes damaged in pneumonitis, then hydrophilic substances like Dtpa can pass through. So you get a second clearance, which is through the general circulation. So you get increased permeability. So this is a little cartoon showing this. So you can give Dtpa, and if this lung capillary barrier is damaged, then the Dtpa can pass through, and you can clear the Dtpa much more rapidly via the blood. You can inject stuff into the blood, like labeled red cells or this inherited transferrin, and you can show activity passing the other way. The only problem is these aren't gaseous, and it's very difficult to inject gases. Xenon is very unpleasant if you inject it, and krypton doesn't last long enough to work through the circulation. So this is a series of dynamic images showing clearance of Dtpa from lungs. Each one of these panels is a 1-minute image. So, but it's not specific. You can get abnormal permeability in any diffuse lung disease that causes a pneumonitis, including lung sarcoid. And in some places, it's used to monitor the effect of lung sarcoid. Radiation pneumonitis, that tends to be focal because it's in the path of the radiation field. Scleroderma lung, again, this is used in some centers to monitor scleroderma treatment. Smoking, it doesn't matter what you smoke. Doesn't have to be tobacco. it changes permeability. But interestingly, it can reverse in active treatment. So this is from one of Professor O'Doherty's papers, and it shows that in a normal situation, you get a slow mono-exponential clearance, and this is because it's bimucociliary clearance, but in an abnormal situation, you get a faster bi-exponential clearance. This is because you're getting both blood and mucociliary clearance. Now, the reason this is interesting is that this is an old technique, but again, I'm just wondering if we might want to start doing this on some of our COVID patients or long COVID patients to see if they have a persistent pneumonitis, which is causing some of their dyspnea, particularly if they don't have any sign of fibrosis. And there are a group of patients with long COVID who don't have fibrosis, and they may be having a persistent pneumonitis. And that might be treatable, for example, with steroids. So it might be worth reconsidering this technique. So a good interactive session, looking at lung scanning. BQ lung scanning is not dead. We should really use SPECT techniques if we can. We can use aerosols, Technogas, or which is the smoke technique, or Krypton, whatever's available to you. Try and use the best method you can. COVID itself produces new challenges, but also new opportunities, particularly for new research. And we can use aerosol methods to look at pneumonitis, and that might include looking at long COVID. So it might be worth you putting all your brains together and trying to work out how you can use these techniques in this new group of patients. So I'm just going to stop sharing and turn the recording